So moving on to the first session, we have two outstanding speakers with us this morning to help us explore this changing profile of the donor pool and to better understand opportunities and challenges ahead and how they've adapted to take better advantage of the increased availability of organs. Each presenter will take about 15 minutes for their presentation, then they'll both join us together for a panel discussion and Q&A from all of you. I want to emphasize the importance of asking your questions of our speakers. They have they're tremendous resources, they're quite knowledgeable, experienced, and expert in their respective fields. So please take advantage of this opportunity to learn from them. And you can use the tools available to you, including the Q&A tab in the lower left corner of your display. With that said, I'd now like to introduce our speakers. Our first speaker is Dr. David Goldberg. David is the Associate Professor of Medicine in the Division of Digestive Health and Liver Disease at the University of Miami Miller School of Medicine. He specializes in the care of patients with chronic liver disease and cirrhosis, including patients waitlisted for a liver transplant. Our second speaker is Dr. Richard Perez. Rick is the Chief of Division of Transplantation of the Department of Surgery at the University of California, Davis Medical Center, where he leads the transplant program, which has successfully and continuously expanded the number of donors, number of kidneys rather, transplanted at his center, making UC Davis the national leader in the volume of deceased donor kidney transplants annually, year after year. Dr. Goldberg will be presenting first, and at the end of his talk, he'll ask Dr. Perez to make his presentation. Then we'll open it up for interactive discussion with both Dr. Goldberg and Dr. Perez. So Dr. Goldberg, take it away.
So thank you very much for the opportunity to give this talk entitled Changing Profile of Donor Potential, Examining High-Performing Centers. As Kevin said, I'm a transplant hepatologist, so I'm going to focus more on the liver side of things, and Dr. Perez will discuss more kidneys, but of course there will be some overlap. Next. So I do have disclosures related to research funding, related to transplantation of hepatitis C infected donors. And I now like to include my personal connection to organ transplantation. Unfortunately, this keeps growing, but my college roommate did receive a deceased donor liver transplant. My wife's friend's baby had a living donor liver transplant, and subsequently her father was recently a deceased donor after circulatory death. Next. So the goal of my talk is to review the data on the changing profile of deceased liver donors, focusing on these categories here, discuss the operational policies of what I define as a high-performing center, and just briefly discuss ways centers are changing practice to accommodate broader organ sharing in liver transplantation. Next. So how do I define a high-performing center? So for a transplant center, their goal is to deliver the highest quality of care to their population. Next. But who is their population? I would argue that it's patients with end-stage disease who could benefit from a transplant and not simply those that are on the waiting list. Next. Well, what defines high-quality care? Next. So pre-waitlisting, one could say it's access to transplant evaluation or waitlisting those who could benefit from a transplant. Next. Pre-transplant is providing evidence-based care. So in liver disease, you could say ascites management for patients with cirrhosis. Next. Peri-transplant, it's accepting organs if they provide an expected benefit and avoiding organ wastage. Next. And post-transplant, it's evidence-based care to maximize graft survival. Next. The focus, though, of this talk is peri-transplant and utilizing as many organs as possible. Next. So why do liver centers need to increase the utilization of available donor livers? So as Kevin mentioned, the number of organ donors and in liver, the number of liver transplants has increased dramatically over the last 10 years, from just over 6,000 10 years ago to almost 9,000 last year. However, despite that, the number of people waitlisted for liver transplant has increased, and despite a decrease since the peak in 2014, there were still more than 2,000 people on the liver waiting list who died or became too sick to transplant last year, not accounting for those that could benefit from a transplant that were never waitlisted. Next. So what does the changing risk profile of deceased donors look like, and from the perspective of a hepatologist? Next. So there's increased risk donors, and this is a public health service terminology that is changing, but these are donors that have an increased risk of transmitting viral infections to the donor, to the recipient, Next. Or higher risk or marginal donors. Next. And these are donors that have an increased risk of having some adverse outcomes and are thought to be lower quality. So in liver, there's the donor risk index as one measure of quality. Next. But there's other ways of thinking of donors that have an increased risk of graft failure. This could be primary non-function, early allograft dysfunction, or other graft complications such as cholangiopathy or bile duct problems. Next. And again, the risk of adverse outcomes are modified by the recipient characteristics, and there is an importance of donor-recipient matching. Next. So this is just a brief summary of just some of the characteristics of donors 10 years ago versus last year. Now, what's interesting is that the median donor age did not change. The number of donors that were obese did not change much, but we see that there was a dramatic increase in the number of DCD donors, but also the mechanisms of death. So we see that the number of blunt injury donors went down, the number of cardiovascular went up, and the largest relative increase was donors with drug intoxication. And what we also see in the last row is that even among those without a drug intoxication mechanism, active drug use has dramatically increased among deceased donors. Next. So when is it in the patient's benefit to accept a quote unquote marginal liver? Next. So there have been studies that have looked at the acceptance benefit of accepting a given liver that can be quantified. And this is based on the graft quality. So is it a better quality graft? The patient's severity of illness, the need, and the likelihood of getting a similar or better offer in a reasonable amount of time. Next. So these are data from Michael Vogt that was published in 2015, where it looked across the spectrum of lab MELD score and donor graft quality, and when there was an expected benefit for a recipient to have a liver offer accepted. Now, obviously, the benefit went down as the donor quality was quote unquote worse, and the benefit was greater with the higher MELD patients who were sicker. But this is one way to think about for a given patient, is it in their best interest to have a liver accepted? Next slide. Now, as we had shown this a few years ago in the Journal of Hepatology, is that there's wide variability in center practice with respect to organ acceptance. Next. And this is associated with patient mortality. Next. So what you see here is this is when centers have a patient at the top of the list, and we looked at this at lower positions. This is within each region. This is the percentage of time that a center accepts the organ for a given patient. So you see there is wide variability. Each dot represents a different center and the likelihood that a center will accept an organ. Next slide. But not surprisingly, centers that accepted more had a much lower mortality. So those centers that said yes more than half the time had a 6% mortality for their highest patients. And those that said yes less than 30% had more than a threefold higher mortality. So obviously not a surprise, but if you accept organs for your sickest patients, they're less likely to die. So this is something that we need to strive for. Next. Next. Now, these are data from the group at Hopkins where they looked at the variability and acceptance of marginal livers, and they did a phenotype centers into aggressive and non-aggressive. But what you see is that aggressive centers were more likely to take older donors, donors that were hepatitis B core antibody positive, hepatitis C positive, that were regionally imported, and that were obese. So not all centers behave the same way. Next. So what have been the temporal changes in liver transplants from higher risk donors? So you see that within liver donors, there's been a dramatic increase in almost a doubling in the number of donors that were obese. Next. So the absolute change was more than 1,000 donors over a 10-year period and a relative increase of 67%. Next. Utilization of hepatitis C antibody positive donors has had an increase of over 600, which is a relative increase of more than 350%. Next. DCD donation in liver still lags behind kidney, but there's been almost a 1.5-fold increase in the number of DCD livers that were transplanted. And next. And older donors, while still relatively rare in liver transplantation, have been increasing. Next. So what about livers that have macrosteatosis? Next. So if you just keep clicking through this, sorry. Next. So these, we'll go just click all the way till the end of this, sorry. So what we see here, and again, not all donors have quantification of steatosis because there's no biopsy, because a biopsy is not performed. But what you see is that the percentage of donors with more significant steatosis, more than 20%, has more than doubled over the last 10 years. So centers are becoming more aggressive in what they use with donors with steatosis. Next. But not all centers and not all regions behave the same way. So this was a study from the group at Columbia where they looked at regional differences in utilization of older livers. Next. And they looked at donors that were over 70 over a 13-year period to look to see where were these donors utilized. And they found that more than almost 40% of these livers were transplanted in two regions. Region 2, so the Mid-Atlantic, and Region 9, New York. Next. And what you see is that some of the areas where there's a relative greater need, such organs are rarely used. So Region 5, which across all organs is an area where there's thought to be a need, donors that were over the age of 70 are infrequently used, whereas they're used much more in Region 9, New York, where nearly 13% of liver transplants during this period were from donors that were over the age of 70. Next. Now, what about DCD livers? So again, this is a busy slide, but what you see here is that the number of DCDs transplanted at centers across the US varied, where there were many centers that did not do a single DCD liver transplant over a 10-year period. And then you have centers here on the right that did more than 200 DCD liver transplants over 10 years. Next. And I highlighted here, and there should be a way to sort of commend these high volume centers, but these are the centers that each did more than 100 DCD livers over a 10-year period. And you see, it's a very small number of centers, but something is different in sort of the willingness to accept such organs. When you see 2 of the 3 highest are part of the Mayo Clinic program, this is Mayo Clinic Arizona and Mayo Clinic in Jacksonville, that those 3 centers, along with Ochsner, did more than 600 DCD livers over this entire period, far more than all the other centers. Next. Now, hepatitis C positive donors is something that's near and dear to my heart, and we've seen increased utilization in these livers, but also improved outcomes. Next. So one thing to note is that because of the way data are collected, pre-2015, we did not know the viremia status of donors in UNOS data, and we don't know the viremia status of recipients. Next. But what we see here in this landmark paper from Lisa Foreman is that Hep C positive recipients in the pre-DA era, so before our new Hep C regimens, did dramatically worse. Next. But what we see, this is patient and graft survival. Again, Hep C positive donors do worse. Next. Next. Sorry, click through, sorry. However, what we see now, next, is that in the current era, the outcomes are almost identical. Next. So what you see here in red is that this is the pre-DA era, and whether the donor or recipient had hepatitis C, survival was worse. Next. However, in the current era, whether the donor or recipient has hepatitis C, the outcomes are no different, and this is due to the advent of hepatitis C therapies. Next. Now, what about utilization? So this was a study from the group at Hopkins where they looked at center variability in utilizing donors that had hepatitis C, and they looked at 3 groups: Hep C negative, Hep C aviremic, that was antibody positive, meaning a prior infection or prior exposure, and Hep C viremic. Next. And what we see is that there was progressive increase in the utilization of antibody positive, but especially NAT positive for Hep C viremic livers over time. Next. However, this utilization was concentrated in a small number of centers where, similar to what we saw with DCD, where the practice patterns of a few differ from those of the rest. Next. And what we see there is that there was sort of clustering between kidney and liver centers that used a lot of these organs, but there was some variability in that there were some centers that were high volume utilizers of Hep C viremic livers and not kidneys, or vice versa. Next. I'm sorry about this. But now, obviously, using such organs does not come without risks. And these are data from the Mayo Clinic looking at DCD livers and whether they had steatosis or not. Next. And what we see is that it was not a benign thing to get a steatotic DCD liver. So these recipients were more likely to have cardiac arrest with reperfusion. Next. Post-reperfusion syndrome. Next. PNF, primary non-function. Next. Early allograft dysfunction. Next. Biliary complications were slightly higher, although this did not meet statistical significance. Next. And maybe more severe acute kidney injury in recipients. So again, getting a steatotic DCD liver was not a benign thing. But next. But this is what I think what matters most is that early period may be rocky, but at the end of the day, looking out 5 years, graft and patient survival was no different. So you can weather that early rough course, but things will be okay over time. And this is something centers need to be willing to recognize. Next. Now, next. So what about outcomes from marginal liver? So this was a recent study published in JAMA Surgery by the group in Baylor, but they looked at deceased donors over a 15-year period. Next. And they looked at marginal defined several different ways based on the donor risk index, DCD, and national share, steatosis. Next. And they broke it up into three errors. Okay, next slide. And what's interesting is they found is that if you look in the far left is 2002, 2006, these quote unquote marginal livers outcomes were worse. But over time, as you look to the right, the outcomes now based on these definitions are no different. Next. And again, looked at other ways, the hazard ratio over time, what you saw is that these worse outcomes from marginal livers are no longer seen. Next. And again, next, this is just showing it just in the interest of time. I wanted to have just a couple of brief slides about changes in liver allocation with the acuity circles, now a broader sharing based on distance from the donor hospital to the transplant center and MEL threshold, and differences in allocation points for patients with exception. Next slide. Just something to think about. What's been going on at the center level is there's been variability and changes in practice and how this has affected centers. And these are data for a paper that's under review. And what we looked at is the 6 months before acuity circles and the 6 months after. What we see is there were only 2 centers that had an increase in volume and decrease in flight, consistent distances. There's no data on flights for procurement and UNOS data, so we had a basis on distance. Next slide. About half of centers, though, saw an increase in volume and an increase in flights, which arguably is okay if you're flying more, but you're doing more transplants. That is something that probably the center's willing to do. Next. There were then a series of centers, 20 centers, that had a decrease in volume, but decrease in flight. So either due to, a subconscious or conscious decision, they're traveling less, but as a result, they're doing fewer transplants. Next. But then there's a subset of transplants that you could argue are the biggest losers, where over the 6-month period, and this wasn't just a COVID effect, because this was seen across the country, where centers did fewer transplants, yet traveled more, which obviously, if this is seen over time, may be something that may make centers financially sort of in trouble if they can't do the same volume, yet they have to travel more. Next. So in conclusion, there's changing characteristics of the organ donor pool with older donors and more medical comorbidities. Outcomes are improving among recipients of livers from marginal donors. Centers vary in practice. Appropriate donor-recipient matching is needed, and peri and post-transplant care to allow for good outcomes. And the transplant community needs to continue to focus on utilization of organs from marginal donors to increase the number of life-saving transplants. And with that, introduce the next speaker, Richard Perez, will talk to us with more of a focus of kidney transplantation.
Dr. Perez, I believe you may be muted.
Can you hear me now?
Yes, we can hear you.
Well, thank you for allowing me to participate in this symposium. I always look forward to working with the Alliance. So my talk is going to be about an aggressive approach to increasing deceased donor kidney utilization. Next slide. I have no financial disclosures. Next. So this is, I think, the reason why I was asked to talk, because as you can see, over a period of about 10 years from 2008 or so to 2016, we quadrupled our number of deceased of transplants. But maybe sometimes it's not always good to get what you wish for, because we then had, and I can talk about this later, a little downturn in volume for a number of reasons, but we think that we have corrected the ship and we're back on our way. Next. So the reason that we were able to do what we did was because of our vision, and that is to make transplantation a successful reality for as many people as possible by expanding the pool of organs utilized. Next. And, you know, when you've seen one transplant center, as the saying goes, you've seen one transplant center. But I think for a successful center, you have to have at least some elements of all these various variables that have been talked about over the last day. Next. So when we set out to do this, we specifically targeted this group of types of donors, and we looked at our practice and tried to be creative and make changes in our practice to incorporate as many of these types of donors as possible. Next. And because it was essentially utilizing organs that were outside of our comfort zone, I think one of the main components is an incremental increase in risk tolerance. And so for each of these areas, for instance, with AKI kidneys, we were at first taking kidneys with very mild renal dysfunction, and then we gradually inched up our threshold till now we're comfortable taking selected kidneys from donors that are on renal replacement therapy. Likewise, the small pediatric donors, at first we were only doing 10 kilos, and then gradually with experience we went 8, 6, 4, 2. And with warm ischemia, cold ischemia, and then with hypothermic perfusion, all incrementally we increased that. And I think that's a very important point. Next. So one of the things that we incorporated early on was hypothermic machine perfusion, and I think that's very important, especially, well, for many reasons, but I think it does expand the limits of cold time that you're dealing with. If you have multiple transplants, you're able to keep these kidneys longer. When you're dealing with high-risk recipients, elderly, which a lot of these marginal kidneys go to, it really helps to have a kidney that works right away in managing that patient, and pumping kidneys certainly will do that. And then it's an additional assessment tool in these other types of kidneys, which I'll touch on briefly. Next. So we published this, and we use them. We pump all of our small pediatric donor kidneys for a couple of reasons. It helps us to do the bench work, but more importantly, I think it does vasodilate these vessels and allow these kidneys to work quicker, and we think it may also protect them to some degree against the thrombosis risk. Next. For anatomically complex kidneys, like horseshoe kidneys, or here we have a pancake kidney, kidneys with surgical trauma, we'll often put them on pump, and it helps us to do the repair or reconstruction, etc. Next. So one of the important components of our program is we have the attending surgeon that's involved in all these organ offers very early on, and going over the donors with a fine-tooth comb. And I think with the attitude that it's a yes attitude always, has been discussed at other programs too, but attending involvement early on I think is very important. Next. So with, of course, with standard kidneys, you can have a one-size-fits-all approach, but when you have these kidneys that may have a little bit more limited renal reserve or a risk of early failure, then sometimes you have to spend quite a bit of time both optimizing.
Dr. Perez, it appears you may be muted again.
Sorry about that. But donor and recipient matching is very important, especially with these higher risk, somewhat kidneys with marginal reserve or with a higher risk of early failure. Next. So we think that patient readiness is very important when doing new things. And by that, we mean the patient needs to be educated in terms of what they're getting into, a higher rate of DGF with AKI kidneys, being on dialysis for a longer period after transplant, a higher early graft loss rate with the small pediatric on block kidneys. We have a special consent form that and education that we give to these patients. But not only that, the support people need to know exactly what the patients are getting to, particularly with these elderly patients that receive these grafts, and may take them quite a while to rehabilitate. So they need to know that sometimes they may need a closer follow-up and more frequent follow-up, and then management of expectations both by the dialysis unit and the referring doctors is very important. Next. We have a very active waitlist management team. We didn't when we first started, but that's something that's evolved. But the highest risk elderly patients are seen annually. We have 3 nurse practitioners that staff this, overseen by a surgeon. And then we use the OPTN kidney offer potential tool to prioritize the workload. So we focus on those patients that are most likely to get organ offers soon. Next. And then one aspect that I think is sometimes underestimated is the functional capacity and the ability of the patient to really prepare themselves by increasing their physical activity and honestly getting themselves prepared for the event. So most of these patients that come into our program are actually transplanted within 2 to 4 years. So we see that as a time where we can have the patient be involved in getting themselves ready for transplantation. So we actually have an evaluation of their physical function by climbing stairs when they're first seen. Every time they're coming to clinic, they're involved in exercise by climbing stairs, and then on admission. And so it gives the patient a real concrete sort of picture of where they are and where they need to be, because we will tell them that if they're not able to perform up to speed, we will actually send them home when they come in for transplant. Next. Now, of course, when you're making changes in your practice, it's very important to continue to monitor your outcomes frequently. So everything's data-driven, frequent analysis, focusing on factors that contribute to adverse outcomes, frequent root cause analysis for problems that are identified, and then you make modifications to your clinical practice as necessary. Next. So I'll just go through a couple of the types of donors that we've used, and so we have a very large experience with donors with acute kidney injury. Next. Again, we pay close attention to donor age, history, comorbidities. Urine output used to be something that we used to insist on, that these kidneys, these donors are making urine, but we are now not as focused on that. We look at, again, as I mentioned before, initially we had only accepted kidneys with mild renal dysfunction, but now we're not really limiting it to that. We looked at the quality of the flush, biopsy, and the only thing that we're really looking for is the absence of diffuse cortical necrosis and the absence of chronic renal disease. We need to be confident that the kidney injury is acute and reversible. And then we always put these kidneys on pump, and we try to minimize cold ischemia time. Next. So we're in the process of writing this up, but this is one of our publications where it's common to use kidneys that have DIC in the donor or glomerular fibrin thrombi. But many places turn down donors that have diffuse, defined as greater than 50% of the kidney has, 50% of the glomeruli have fibrin thrombi. So we looked at our experience where we had 16 donors that had diffuse fibrin thrombi, most of them over 80%. And you can see they were all young donors, trauma victims, with relatively low KDPI. Next. So out of the 24, we had 2 that failed, and we compared it to our controls, and essentially they had a higher rate of graft function, but when you looked at their long-term follow-up, they had better or near better renal function. So diffuse fibrin thrombi is not a contraindication to transplantation in our eyes. Next. So this is something that's very dear to my heart. We have a large experience with very small pediatric donors. Next. These go down to as neonates. We've done about 30 neonatal transplants. Next. For anybody that wants to look at how we do this, we have sort of an amateurish video on YouTube. It has now 1,200 views. Please put your please put a thumbs up so we can maintain our 4-to-1 positive review. Next. And here's we put these in the in small, low body weight, low immunologic risk patients with a low risk of recurrent disease. We don't want to have to biopsy these very small kidneys. Bladder capacity has to be good. No hypercoagulable state because of the risk of thrombosis. And then, as I mentioned before, a good education, understanding of what you're getting into, slower recovery, and adequate support. Next. We do the standard en-bloc technique like most centers do. Next. And we have several publications now looking at our series, which is probably around 300 by now. We have here, this was published a couple years ago, showing our case controlled, looking at brain dead versus DCD in very small kidneys, less than 10 kilos. And the average age was a little less than 2 months. You can see the pump characteristics are very different than in adults with low flows and high resistance. Next. So this is a series that had, and here's the recipients. We put them into relatively young relatively light patients, we had a higher delayed graft function in the patients with DCD donors. And over the 6-year period, this isn't a 1-year graph, but 6-year period, we had 23% of the grafts lost in the DCD and a fairly high amount of urologic complications. Next. So when you look at it, most of the graft losses are early, but as with all of these studies that come out with pediatric on blocks, if you weather the first year, these grafts tend to go very well, have good function, and last for many years, as you can see here. So these are even the small DCD kidneys, less than 10 kilos, have good long-term graft survival. Next. And here's the function of the DCD versus brain death. Next. Urologic complications, I'm running short on time, so I'll just say there is a high urologic complication, 10%, but as you can see in the graph, these patients do very well over time. Next. So currently, this is our inclusion criteria for pediatric on blocks. Next. I think I'm going to have to wrap it out. I'm running out of time. For ECD and high KDPI kidneys, we put them into older, smaller recipients. We minimize the immunologic risk, try to minimize cold time, and we consider dual transplants as well. Next. Donors with increased risk of infection. I don't think I'm going to say anything here, although we're doing, I think, pretty much what others are doing. Next. Next. And I'll just say briefly that I think for kidney transplantation, as with others, the next paradigm shift is going to be normothermic perfusion. Next. We've started to delve into this where we've looked at the combination of hypo and normothermic perfusion. And I think that that's really an exciting application for the future. Next. So in summary, what's necessary for expanding the organ pool? I think you need an aggressive vision and a sincere commitment, a willingness to increase risk tolerance incrementally, efforts to educate all stakeholders involved, both within your center, your patients, the families, specific matching of organs and recipients, frequent data-driven analysis, and then adjustment of your clinical practice accordingly. Again, thank you for the opportunity to present before the group.
Great. Oh, fantastic. Thank you so much, Dr. Goldberg and Dr. Perez. We have about 12 minutes left for Q&A, and we have a number of questions already queued up. So let me launch right into the questions. We have a question here from Donna Smith from Sierra Donor Services in Sacramento, California. I have a question for Dr. Goldberg. Dr. Goldberg, given your interest in improving OPO performance and increasing donation, I'm interested in your thoughts. As OPOs continue to seek to increase DCD donors and older donors, we are finding challenges with utilization of these organs, and many of these organs are being discarded. We know that many of these organs can and should be used, but barriers such as timing, logistics, and ineffective processes are often the cause of organs being discarded. What can we as OPOs and transplant centers do together to overcome these barriers to helping more patients and avoid organs being discarded?
Sure, and I think there has been work, within UNOS about to sort of change the sort of expedited placement and to also ensure that sort of centers that are getting offered these are centers that have historically used them. I think, and again, as not an OPO, I know that, having worked with certain OPOs, I know when I was in Philadelphia before and then came down here, they've been working with our local transplant center to help place organs that may not be used in Philadelphia, but can be used here in Miami by, an aggressive center to build those partnerships. I think something that would be helpful is, I know for one thing, the SRTR has worked on sort of these aggressiveness metrics is, transparently presenting data not just on centers, getting people waitlisted and transplanted and post-transplant survival, but more transparency about center aggressiveness and center acceptance rates. Because I think maybe that, that may help both the consumer, the patients, but even the providers know what their center is doing, and also to sort of help them work with the OPOs. I know as someone who does research in this, I was always aware of which centers were accepting which organs. And when I would talk to colleagues, they may not be necessarily aware of that. So I think transparency across the board is important.
Great. Thank you very much, David. This looks like a question for Dr. Perez. Does your OPO provide perfusion services, or is this a program based at your facility? And that's from Anonymous.
Our OPO does provide perfusion capabilities. They haven't in the past, but they do now. But we have had our own perfusionists here at our hospital for the last 15 years. So we have done it ourselves. But we want to work with our OPO as well to perfuse selected kidneys, and I think it's good to have somebody in your region doing it, because it does make a difference, especially as I look to this new allocation model, and it's going to take longer to work through the list. I think people will be more comfortable accepting kidneys that are on the pump as it takes more time to allocate these organs. So whether I don't think it's necessarily important for the OPO do it or the transplant center, but you need to have it available in my mind.
Great, thank you very much. Here's a question for you, Dr. Goldberg, from Joel Chase, Life Center, Cincinnati, Ohio. It's surprising to see that transplant centers have not performed a single DCD liver transplant in 10 years, some transplant centers. Is there any data on how many of those are pediatric centers? And secondly, do most pediatric liver transplant programs consider DCD donor organs?
So the second part is easy. There have been a couple studies that have been recently published in liver transplantation and transplantation about pediatric DCD utilization. And the long and short of it is, the data suggests that the outcomes may not be any worse, but most pediatric centers historically have not really used many of them. Those centers that I focused on, I believe I was looking only at adult centers. There are many adult centers that have never performed a DCD or performed 0 or 1 in 10 years. So yeah, I think the pediatric, I think sometimes there's more concerns with the sort of concerns for cholangiopathy and whatnot, potentially putting that into a 15-year-old patient or something like that. But there are many, many adult centers that have not done them or don't.
Thank you for that response. And I just want to comment, it's really wonderful to see there's many, many questions that are coming in on the queue here. So we're going to use the remaining 7 minutes quite constructively. Here's a question from Rick Haas in Gift of Life in Philadelphia. What role does normothermic preservation play for those centers doing large volumes of DCD livers? Could you also talk about the changing pool of patients waiting for a transplant, alcoholic hepatitis, hepatitis C, and the role that these things might play in organ utilization?
So in terms of the machine perfusion, I think all of the data suggests that it really is potentially a game changer, but I'm not sure where things stand, and I don't think it's FDA approved yet. So still, these have largely been done in trials. And I know some of the companies that have done this have said centers can continue to do X number after the trial ends. I think identifying which donors to use it in is going to be key. And I think ideally, some of the studies out of the UK has shown it's not just making the donors better, so to speak, but it's getting organs used that wouldn't have been used otherwise. And I think that's really where the key is on my mind, is sort of donors on the fringe. In terms of the recipient pool, there has been a lot more alcoholic hepatitis, a lot less hepatitis C. I'm not sure how that really would change the utilization of donors per se. The only question you could argue is that if we're transplanting more and more super sick patients with high MELD scores, a concern theoretically is may centers be less likely to use those more marginal livers in those patients. I think it still really remains to be seen.
Great, thank you very much. Here's a question for Dr. Perez. This comes from Kevin Meyer at LifeGift in Houston. Great presentation and thank you both. How do you all manage the inflow of offers when operating with so many innovative and measured risk approaches? Assuming you have very few screening criteria, but can you back that up by actually using these kidneys for appropriately matched candidates? And thank you for leading in practice of using net benefit transplantable kidneys. So important to share your practice with the larger community. Thanks again.
The question was, how do we manage all the offers?
Yeah.
So that became an issue in our center as we grew. We couldn't keep up with all the offers. And so we have outsourced it now, and we have an all-call team that takes all the organ offers for us and coordinates the transplants. So that's how we do it. They take the initial screening and then they call the surgeons.
And just one other thing, I just said, Miami, so, their transplant program has sort of grown. I think they did 500 kidneys last year. Just a shout out. The way they've done it here in Miami is that there's one nephrologist, Giselle Guerra, who literally takes essentially every organ offer. I'm not sure if she sleeps at all, but the purpose of that is she feels them all, but then the surgeons actually can get sleep during the night and sort of wake up in the morning knowing they have X number of transplants lined up. And obviously it takes an added layer of trust between the nephrologist and the surgeon, but that's another model that they've done here that's worked.
Great, thanks for sharing that. And just kind of to anchor us in where we are in time here, since we started a little bit after the top of the hour, we've got about 6.5 minutes left. And again, plenty of questions. So the next question comes from Anonymous. I would like for both speakers to comment on acceptance/use of past COVID positive donors and how they would categorize that risk.
Well, I think the challenge with the COVID donors is it depends what you mean by post. So I think if someone is diagnosed with COVID in the hospital, I would have strong reservations personally, because we know it could take 2 weeks at least to clear it. If someone had COVID, let's say 2 months ago, I don't think there would be any issue personally.
Dr. Perez?
We haven't encountered that yet. I mean, we would be very hesitant to use it. I think that the real risk is probably very small in terms of COVID, viremia that would be transplantable. But it's too early to, I think, use these organs in my mind. I don't want to be the first one to do it.
Okay, thanks a lot. The next question is a question for both of you. Maybe Dr. Goldberg, you can answer first, and then Dr. Perez. So from Steve Zanders, what are the presenter's thoughts on controlled mild hypothermia, either after declaration or during consideration of DCD to preserve function prior to explant?
So I could speak in liver. I'm not aware of any data specifically suggesting that would change outcomes. From what I understand from the UCSF studies, when they did that in kidneys, there was no thought that it actually hurt the liver, but I'm not aware of any data to show that that would improve outcomes or prevent cholangiopathy in liver donors.
Dr. Perez?
I think that Dr. Darren Malinkowski's data is pretty convincing that it does help. The question is it better than post-procurement hypothermic perfusion? And I think that's the study that they're trying to do now, comparing hypothermia in the donor versus hypothermia in the organs, at least in the kidneys after procurement. But I think there's definitely benefit.
Great.
Yeah.
Thank you. Another question for you, Dr. Perez. Can you comment, again from Anonymous, can you comment on biopsy findings that you find concerning? Specifically, what finding do you accept that others may not?
Well, the way I approach the biopsy is I use it as another piece of data that goes into the whole picture. So I don't have a threshold for instance, percentage glomerulosclerosis. If everything else looks good and the only reason that a kidney is being turned down is because it has a high percentage of glomerulosclerosis, I will still consider it. I will often rebiopsy the kidneys, and if I think that there was a subcapsular specimen with a high degree of glomerulosclerosis. So, and the, people talk about vascular changes, but that's so subjective, and the vascular technology, the ability to get a good vascular sample on a frozen section is very limited. So I use the biopsy as another element that I consider along with everything else, but I don't have, I will transplant kidneys that have a high level of glomerulosclerosis if everything else is okay. And then of course I'll put it in an older patient with maybe a lower metabolic need. But the field has been saying this for years, that we need a really good randomized controlled trial looking at the real role of biopsies, because so many people think that too many biopsies results in more kidneys being discarded, and our colleagues in Europe don't even biopsy a lot of old kidneys, and their outcomes aren't any worse than ours.
Great, thank you. We also have a comment that you don't need to respond to, Dr. Perez. It just it says, please ask Dr. Perez to share the phone number for his call center, ! So there you have it. I think people can find their way to your program through the conventional means. And then now we have a question for Dr. Goldberg, with just a little over 1 minute left in this session. This question comes to us from Jan Finn in Kansas City. Dr. Goldberg, thank you for the data review. How is this being utilized to affect improvements across the country? Is it being widely shared or used by UNOS committees?
So I can't fully speak to it as someone who's not on those committees. I'm not sure how this is used. I think, when the SRTR transitioned to their different tier systems, one of the things that they started to show was, probability of getting a deceased donor transplant faster. But to my knowledge, and Kevin, I know you've been involved in committees, I'm not aware of how these data are being used. I think it should be used more. I think we need to celebrate the centers that are taking these organs, and I don't want to say shame, but sort of bring up those that are not, and sort of in some fashion. I'm not sure how. Great.
Well, thank you. And I couldn't agree more with you. I think we heard it said well from John Snyder yesterday. I think the availability of data which can help us really understand where we have gaps, both on the OPO side and the transplant side, is really unlimited these days, and the access to that information is widely available. So anything that any of us can do to increase the visibility into that will be time well spent. So we've come to the end of of this session. I really want to thank both Dr. Goldberg and Dr. Perez for their excellent presentations, and all of you for submitting your questions, and for our speakers' responses to those questions. This has been a fantastic hour packed with a lot of learning opportunities. So thank you both very, very much.